Periprosthetic fractures. Intraoperative fractures risk is 3.5% in uncemented and 0.5% in cemented. While cemented tends to fracture after 5 years, uncemented fractures within 6 months. Risk factors: press fit. Number 2, osteoporosis, Paget disease. Number 4, distorted anatomy. Number 5, revision surgery. When poor classification, trochanteric type A is AG and AL. Type B is at the bed of the stem. The B1 is well-fixed stem. B2 is low stem, good proximal stock. B3 is loose stem and proximal bone stock and poor proximal bone stock. C is distal to the stem. In type AGAL can be managed conservatively or if needed, and there is a displacement, a claw plate can be used. If around the stem B1 with well-fixed implant, unicortical screw proximally and distally bicortical screws with a variable angle plate. B2 is a loose stem with good proximal bone stock. A long porous coated cementless stem more than 2 cortices below the diameter should be placed. Loosening will be indicated by the previous history, prior hip pain, thigh pain, subsidence, cement fracture, radiolucency, and dislocation of hip. B3 is loose implant with poor bone stock. Diaphyseal fixation stem is if adequate bone stock 4 cm proximal to the isthmus. Impaction bone grafting is possible. Attach abductors to prosthesis or to vastus lateralis. Distal to stem, avoid the implant and you can plate plates with cables. If any plates Ogden plate. Another classification by Professor Haddad, Duncan and Haddad. A is at the apophysis, that is greater trochanter, lesser trochanter. B is bed. C is clear. D is dividing the implant. E is each of the fractures. F is facing. Whenever talking about periprosthetic fractures, fix or revise. Remember the words fix and revise and decide accordingly. If acetabular fracture, add screws, stable cup, unstable cup, remove the cup, stabilize the fracture and insert. In patient with pelvic discontinuity, cup cage reconstruction can be used.